So let me start again. Thank you really very much. Let me start by asking, I want to get an idea of who's in the room. So let's start with, are there any medical doctors? Yeah? Yeah, it's okay. You can be proud of that. Yeah, sorry. Okay, let's make sure we rule out any attorneys. Okay, we are free to speak. Okay, just speak candidly. Okay, nurses. Okay, some nurses. Okay, good. Social workers. Okay, substance use counselors. Wow. Okay, a lot of substance use counselors. And who did I miss? PhDs, other doctors. There we go. Okay. Okay. So psychologists. Ma'am, your PhD? No. I thought this young lady had her hand up. No? Okay. Who'd I miss? Students. Students, let's see you. Huh? Students? No? Okay. Anybody else I miss? Oh. Emergency services. Okay. How about administrators? More emergency services. Okay. Administrators? No? Okay, good. Mostly clinicians? State government. Okay. I can relate because I'm a state government guy. So as Gary said, I've actually been the director of two statewide SBIRT programs in Washington State and in the state of Georgia, and have just recently now moved to Columbus, Ohio, where I'm now the director of the Ohio SBIRT project. So this is what I've done for the last 10 years of my professional career, and hopefully I can share some of that knowledge and expertise with you today. Let me ask this question as well. I want to get some idea. I'm going to ask a couple of questions. First, who's familiar with substance use screening, brief intervention, referral to treatment? Okay, some familiarity. Okay. So those of you who aren't familiar, what brought you here today? Curiosity. Okay. It's okay to say CEUs and breakfast. Okay. Yeah. You teach. Okay. Excellent. Okay. So let me ask this question then, and feel free, anybody, feel free to help me with this. What are your expectations for today? What do you hope to know when you leave? How will you know that this was a successful 2 hours of your life that you will never get back? Okay. How will you know that? Yeah.
I want to know, my students are very concerned because like the war on drugs didn't work, and how are you going to stop this? I mean, there's big issues with these illegal drugs and just a lot of problems that I didn't realize in the community until I started teaching these drugs in our culture.
Okay. So what are strategies to address substance use in our communities? Okay. So if you know a little bit more about that when you leave, that will feel like that was a successful couple of hours. Okay. Sure.
Tried instituting this type of program 10 years ago. Met massive resistance.
Yes.
Trying to find out what is being done differently to move it forward today.
Okay. So tried to implement SBIRT 10 years ago, and people said, yeah, maybe not. Okay. And so maybe we have some new strategies. We've certainly learned some things in the last 10 years because I've been around that long, and I feel your pain, brother. Okay. So we'll talk a little bit about that. Who else? How else? What else? When you leave today, how will you know this was successful for you?
That I have something to bring back to my workplace.
Something to bring back to your workplace. Guess what I learned today? Okay, great. I think we can accomplish that. Yeah. Anybody else?
Well, implementing into the health system, into the practitioner's office.
Okay, okay, a little discussion about implementation. Okay, interested in implementation. Okay, well, I think we can accomplish that as we move forward today. Most of my talk today is going to be really about reconceptualizing our understanding of substance use problems. And we're going to talk about that in the context of SBIRT, but we're also talking about that in the broader context of healthcare in the United States. And so part of that context, as all of you know, is healthcare reform, which in some ways is a misnomer because a lot of the reform is actually insurance reform, payer reform, but there is actually some healthcare reform parts of that as well. And so the Affordable Care Act, things like meaningful use, patient-centered medical homes, these may have been terms you've heard. Basically, a lot of these changes have to do with significant more emphasis on prevention and significant less emphasis on treatment, significant more emphasis on data and on using evidence, significantly less focus on just sort of doing stuff because that's what we've always done. And so there's some really big changes. And it's really, I think it's fundamentally important, and maybe the biggest change, because so many of you work in behavioral health, one of the biggest changes is integration. Now, I've been in the substance use field for nearly 30 years now, and we spent a long, long time trying to get away from doctors and social workers and psychiatrists and anything that smacked of that stuff, right? And we tried to sort of have this nice silo where we had community substance use treatment facilities and they're kind of really independent and all that kind of stuff. Well, now we've come to the place where we want to come back together, right? So integration is a huge key when we start to talk about healthcare reform and the Affordable Care Act and some of the things that are coming along, as well as things like health information technology. So health information exchanges, electronic medical records, those kinds of things. That's really the direction that we're going. And SBIRT really fits into that. And there's a number of reasons for that. First of all, substance use screening, brief intervention, and referral to treatment really is a systems change initiative. It's about changing not only how we think, and in this case about substance use, how we think about it, how we frame it, how we understand it, but it also asks us to redefine how we identify what substance use problems are. So we're going to think different about those problems. We're going to identify them different, and as a result, we're going to treat them differently. So we're going to think differently about the problem, we're going to identify the problem differently, and we're going to think differently about it. And as a result of those things, in many ways, it's a systems change initiative, because the system is going to have to change to accommodate this new way of thinking. There's no way for the old system. What's the line? You can't graft a new idea onto a closed mind. Is that about right? Yeah, it's like that. The system will have to accommodate this new way of thinking. So the system is changing, and SBIRT is part of that systems change initiative. So we're going to think differently about substance use problems. We're going to identify them different, and we're going to redesign them. As a result of that, what I'm going to ask you to do is, the first thing is I'm going to ask you to forget everything you know about what constitutes a substance use problem. All of you walked in here today at various levels of engagement working with substance using populations, but I know a lot of you are substance use counselors, which is what I spent the first 10 years of my career doing before I moved into administration, was doing direct services. And so everybody walked in here with a concept, an idea, a construct mentally about what a substance use problem is, how you know what it is, what it looks like, what constitutes it, all that kind of stuff. So I just want you to set that aside for right now. Can you do that for me? Okay, I see some hesitant nods. I'll give it a shot. Okay. The second thing is I want you to forget everything you know about how we identify substance use problems. In my history, and I'm guessing yours, that we spend, usually how we identify substance use problems is the judge sends us somebody, and then we give them a biopsychosocial assessment, and we ask them things like, how old were you when you first started smoking marijuana, and do you have a family history, and how much legal trouble are you really in, and all those kinds of things. And then we arrive at a diagnosis, and we use the DSM. What DSM number are we up to now? 5, thank you, I get confused. I go back so far I remember the DSM-3. That's sad, isn't it? Excuse me. So we come up with a diagnosis based on the DSM-5, and things have changed, right? DSM-5, quite a bit different now. It's substance use disorders, no abuse, all that kind of stuff. So we do that. We have a diagnosis. And then, so I want you to forget about that. I want you to forget about how you currently and how we have historically identified substance use problems. And lastly, I want you to forget about how we treat them. Because everybody also walked in the room today with a model in their head about what constitutes treatment. So most of us use the American Society of Addiction Medicine patient placement criteria too, right? We use the ASAM PPC2. And so we've got outpatient and inpatient and detox and recovery house and day treatment and intensive outpatient and medically monitored inpatient and social detox. We've got all those early intervention and all those kind of different numbers and codes and letters that define what treatment is, right? So I want you to forget about that, okay? So I want you to basically forget everything you know about what makes the problem, about how we identify what the problem is, and then how we take care of it once we've identified it. Because SBIRT asks us to change all of that. Okay? I know, you're going, you gotta be kidding me. So SBIRT asks us, again, as a systems change initiative, to change all of those things. Okay? So here we go. Historically, and we can go back a couple of hundred years, society has viewed substance use and substance use problems in a variety of different ways, so from a variety of different contexts, as a moral issue. 200 years ago, clearly people thought, you know, this is just a moral issue. If you had better morals, if you're a more upstanding human being, you wouldn't be struggling with this issue. It's a sign of weakness. Back in about 1935, Bill Wilson and Bob Smith met in Akron, Ohio, and they did what? Started AA, and they really said, you know, this is an individual problem. Every human being, every person that's got this problem has got to show up at a meeting, got to work the 12 steps, got to, you know, admit their wrongs, got to make amends, all that kind of stuff. It's really kind of an individual thing. Well, it wasn't very long after that when Lois Wilson, Bill's wife, said, excuse me, I may have been negatively impacted by your drinking bill. And so we started Al-Anon, and we started, as I was coming up, started to talk about addiction and substance use problems and alcoholism as a family problem, that a lot of people are affected by it. Okay? Back in the 70s, when I was a young kid, and we were all running around with hair down to here, smoking reefers the size of a corn cob. You remember this? Okay? We really thought about substance use. See, you remember. We really thought about this as a social issue or a social problem. You know, it's the damn hippies. You know, they're dropping that acid and smoking that marijuana, right? And so, and then that was before people started bringing Uzis to the party, right? And you know, rifles and shotguns and machine guns. And once that started happening, we went, wait a minute, this really looks like a criminal justice thing to me. Okay? And so we really focused on the criminal justice aspect. So society over time, and what's important about this is to realize that our understanding isn't static. Our understanding changes. Our understanding of what is a substance use problem, how to deal with it, what constitutes it, that changes over time. It changes with new evidence. It changes with experience. It changes with science, all that kind of stuff. So our view changes, and it continues to change. It continues to evolve, and SBIRT is part of that. So I'm pretty confident that solution to any problem is always driven by its cause, or its presumed cause. In other words, if I think my car has an electric problem, then I must look for an electric solution. If I think the problem is electric, I might check my battery, but I'm not going to check my gas tank, right? So the problem, where I think the problem lies is how I'm going to find the solution. So if substance use is a moral problem, how do I fix it? I changed my morals. Where might I refer a human being to do that? Church. Sure, I'll send you to church. I certainly wouldn't send you to a doctor, right? Wouldn't make any sense. Doctors fix broken legs, okay? Not broken morals. So naturally, my solution would be a moral solution. If I think substance use is a criminal justice problem, what do? What's my solution? Jails, institutions, judges, laws, policy, right? Attorneys, prosecuting attorneys, probation, parole, all of those things. Where do most of our patients come from in the substance use field? Through criminal justice. Yeah, that's part of how we know that we view it as a criminal justice issue, because most of our patients, that's where they come from. Okay? And I think that's really important. I just want you to hang on to that. We all know that. It's been like that since I was doing direct services. It's been like that forever. Okay? But again, criminal justice is our primary referral source. So, if it's a moral issue, we'll send them to church. If it's a criminal justice problem, we have to get judges and all those people involved. Well, for the SBIRT model, we believe that substance use is actually a public health epidemic, and as such, it's a public health problem. The problem is a public health problem. It's not moral or social or anything else. It's public health. In our field, for years, in fact, we were thrilled when people started to talk about addiction as a disease, right? Because look, it takes it away from that sort of it's a moral thing, okay? And it sort of takes it away from all sorts of negative concepts and says these people are sick. People are sick. Let's treat them like they're sick. And so that was like a real seminal moment for us that deal in substance use problems. And we started to use words like prognosis and diagnosis and treatment and recovery and all sorts of terms that are really medical. But on some level, we've never treated this like a medical problem. We continue to treat it like a social problem. And in turn, we frequently treat it ideologically rather than evidentially. Okay? We will treat it from a certain ideology rather than the evidence that supports maybe treating it in different ways. And I think that's also fundamentally important. So if we think about substance use as a public health epidemic, well, actually, let me sort of change. How many of you remember 4 or 5 years ago, we had a flu pandemic? Do you remember this? Do you remember what that was called? H1N1. I have asked that question all around the country, and everybody always knows. As soon as she said H1N1, you went, oh yeah, H1N1, right? She knows that. That was like 4 or 5 years ago. A flu pandemic that never happened, right? And she remembers H1N1. Okay? That's amazing to me. How do you cough? What's the appropriate? Oh, see, so you always know. The appropriate way to cough is like this, right? See? She remembers that. Okay? What's the most important thing you can do to avoid getting the flu? Wash your hands, of course. Look at you guys. Okay? That is amazing to me. You know, this is 4 or 5 years ago. H1N1, cough like this, wash your hands. Okay? We're like robots. Okay? Good for you. Okay? Let me ask you another question. How many people in here know what a normal blood pressure is? Almost everybody. What is it? 120/80. Absolutely. Everybody knows that. You know H1N1, you know what a normal blood pressure is. Can anybody tell me what the safe drinking limits are for a man 65 and older? You're a shill. You just sit there and be quiet right now, young man. Okay? Can anybody tell me? Okay, no more than 1 to 2 drinks per day. You're certainly in the ballpark. I'm guessing. What would you have said? Okay, you're going to go with 1 standard, 7 a week. Okay, so but here's what's important about that. Everybody knows H1N1. Everybody knows cover your cough. Everybody knows wash your hands. Everybody knows 120 over 80. But you say safe drinking limits, people go, well, I don't know. Okay? Part of why we don't know is because, I'm sorry? What's not safe? Well, that would depend on how physiologically dependent you are. Yeah, absolutely. Only depending on how physiologically dependent you are, but absolutely true. But so the reason you know about H1N1, for instance, is because we addressed it as a public health problem. That's why you know it. That's why you know what it is, how to prevent it, how to protect yourself, all of those things, because it was dealt with as a public health problem. Let me ask you this. Who knows what the third leading cause of preventable death in the United States is? It's alcohol and alcohol use. Not necessarily dependence, but alcohol use is the third leading cause. I want that to sink in. The third leading cause of preventable death in the country is alcohol use. Could you imagine if I stood in front of a room full of people like you and said, did you know the flu is the third leading cause of preventable death in our country? Can you imagine the uproar? Can you imagine the public outcry about what we should do about the flu? People would not stand for it. They would go crazy. But I stand in front of rooms like this all over the country and I say, what's the third leading cause of preventable death? It's alcohol. And people go, well, that's a drag, man. Yeah, it's really a drag. Want to go for a drink later? So I think that constitutes a public health problem. And I know that when I start to apply a public health solution to this problem, I will get a completely different result. I will think about it differently, I will identify it differently, and I will treat it differently, those things for sure. But check that out. You still remember H1N1. Why? Because we addressed it as a public health problem. So what's the first thing that happened? The epidemiologists looked and said, oh my God, the flu's coming. What was the next thing that happened? That's one of the things that happened. What else? I'm sorry? Education. You could not turn on your TV without hearing about, you remember this? The flu is coming, and they had maps and where it was going to be, and now it's in China, and it's coming this way, and somebody got on an airplane, oh my God, right? I mean, it was crazy. And then they started telling us this, you cough, and you wash your hand. Most of us don't remember this. Purell wasn't on every door in the country until about 4 or 5 years ago when the flu pandemic came. That's when Purell was a dying company. And next thing you know, they're Fortune 500 because of the flu. Okay?
I think one of the things that complicates this message is that there has been more and more information, possibly evidence-based, put out there that a little bit is even good. And what you hear people saying is, okay, 3 glasses of red wine a week has a preventive quality and a life-enhancing quality, strengthens your systems. And I think you'd never hear that about tobacco. A couple of cigarettes a week is good. You've never heard here a little bit of flu is okay. This is a really confusing message that our children and our teenagers and people are being raised with. So it's a challenge, I think.
Okay. What's your name?
I'm Deborah.
Deborah. I think it's even more confusing than that. And let me tell you why. Where does our public service messaging for alcohol come from? What is that message? You all know it, just like you know H1N1. What's our public service message? Drink responsibly. Who gives us that wonderful public service message? That's right, Anheuser-Busch. Now, correct me if I'm wrong, but it seems a little like the fox may be guarding the hen house here. Okay? Because frankly, you all know this. That is our public service message when it comes to alcohol. Drink responsibly. Now, and trust me, I've asked this question all around the country too. What do most Americans think that means? Somebody already said it. Don't drink and drive. The message is drink as much as you want. Just don't drink and drive, right? Because then you're a responsible drinker. So that somehow responsibility is linked to a behavior, not to the drinking, right? And when I hear that message, here's what I hear. Drink responsibly, right? That's how it sounds to me now, okay? And so drink responsibly is our public service message. And most people think it means I can drink as much as I want as long as I don't drive. Now, as far as it goes, that's an okay message. I don't want people to drink and drive. I'm fine with that. But it's certainly not the best message. And not only is it not the best message, it creates a problem with subjectivity. Everybody makes a decision about what that means on their own. And most people interpret it to mean don't drink and drive. So it has nothing to do with amount or frequency or anything else. It has to do with a specific behavior while you're intoxicated. I think that's a bad message. That's why, part of why we're really confused, you know, but you're absolutely right. There's a lot of confusion, and that's part of what adds to it. So, when we start to talk about, when we start to use a public health approach, then we're going to change what we do, obviously. One of the things is we want people to know that the third leading cause of preventable death in the country is alcohol, is drinking. And I'm going to talk most about alcohol today for a number of reasons. Okay, first of all, it's the biggest drug problem in our country. Everything else pales by comparison. Everything else pales. And we go through, we're a funny trend-driven country. Okay, we go through trends about, and our hair catches on fire. Right now it's prescription opiate abuse. That's what our hair's on fire about right now. Okay, yeah, people shouldn't be abusing prescription opiates. Yeah, it's terrible. But if you look at the numbers, it's minimal. It's not a lot of people. As opposed to you look at the numbers of people who have problems with alcohol, it's huge. In my projects in Washington State and Georgia combined, we provided SBIRT services to around 500,000 people. Okay? About 90% of everybody who walked in the door had had a drink in the last year. At least one drink. I'm not saying they had an alcohol problem. At least one drink. Only about 40% had smoked marijuana in the last year. About 8% had used cocaine in the last year, and everything else was way lower than that, which gives you an idea of how prominent alcohol use is, okay? Because it went from 90 to 40, and then 40 to 8, right? And so most of the drug use was under 10% of everybody who walked in the door of two large public health hospitals primarily, in two separate states on two coasts. Okay? So alcohol is the problem. It really is. If we could fix the alcohol problem in our country, we'd go a long way to solving the social problems related to substance use in our country. Which is not to say that people should be using recreational drugs or illegal drugs. We would anticipate that in my home state of Washington and in Colorado that we'll see an uptick in problems related to marijuana. I would expect that as people figure out how to manage pot being legal, all those kinds of things. But by and large, the problem we really have to deal with is alcohol. And there's other reasons. Some of them are the reasons you talk about. Most people will say, you know, cocaine's bad. Heroin, bad. Okay? Alcohol, not so bad, right? I mean, because when do we use alcohol? Holidays, feast days, fast days, birthdays, Saturdays. You remember, you go back, right? Yeah, good for you. Feast days, fast days, Saturdays, Mondays, Tuesdays, Wednesdays, Thursdays. See, alcohol is part of who we are as Americans. It really is, whether we like it or not. And it's part of our celebrations. It's part of, we drink it at funerals, we drink it at weddings. We drink it at baptisms, and we drink it at wakes. That's both ends, okay? I mean, that's everywhere in between, right? If you're drinking it when someone's born and when someone dies, that pretty much covers everything. So that's another thing. Alcohol is just a part and parcel of who we are. So what we want to do when we talk from SBIRT, we want to learn from public health. Because we're going to take a public health approach, right? And so everything we do has to change. The healthcare system routinely screens for potential medical problems, not real medical problems, potential problems, and provides preventative services prior to the onset of anything acute or anything chronic, and as a result can preclude or delay a person from getting sick. And I have to look ahead at my slides, okay, that will keep people from getting sick. For instance, I have a wonderful doctor in Atlanta, Cynthia McCaleb, and she's my primary care gal, and I see her every January for a physical. Well, this last January, she gave me my physical, and I mean, she takes fluids from every place she can get a fluid from. She pokes me every place I could possibly be poked. She does all, she's really thorough. So I go back to get, to hear the results of the lab tests, and she goes, Steve, excuse me, you're vitamin D deficient. To which I responded, oh no, I'm vitamin D deficient, oh. Okay, and I said, so what, I mean, it's not like, Steve, you have cancer, it's, oh no, I'm vitamin D deficient. I said, so what does that mean? And she goes, well, you could get the rickets. Now, I don't know what the hell the rickets are, but I'm pretty sure I don't want them, right? Okay? So I said, so what do I do? She goes, well, we're going to start you on vitamin D. So now I'm on rickets. It makes you do this. This is what you get. You turn into a cowboy, I guess, is kind of how it works. It makes your bones brittle and bendy and stuff. Anyway, so she gives me vitamin D, right? Now, she didn't give me vitamin D because I had the rickets. She gave me vitamin D because she identified a potential cause for the rickets that she could intervene on now to keep me from ever getting them. Does that seem pretty sensible? How many of you ladies get your mammograms and your pap smears? Good for you. How many men my age get their PSAs? Good for you, okay? Okay, why do we do that? Right, because we know that if we identify something early, we can either keep it from getting bad or we can keep it from ever happening. Vitamin D in and of itself is not a problem. I felt fine. The problem is down the road, I could get sick. So she said, well, let's not wait for you to get sick. Let's treat you now. Okay? So we routinely screen for stuff. When was the last time you went to the doctor and did not get your blood pressure taken? Never. Okay? In my language, in the SBIRT language, we would call that a universal screen for hypertension. Okay? Universal. Everyone gets it. We don't walk around the waiting room going, I think you're okay, Marcy. I think you're fine. Oh, you definitely need a blood. You just look hypertensive to me. Okay? You just look like the kind of person that'd be hypertensive. Marcy, you're fine. I can just tell by looking at you. Wouldn't you think that was just crazy? If the way we decided who needed to be screened for hypertension was a person that just looked like they did. Okay? Unfortunately, that's frequently how doctors identify substance use problems. That's frequently how a lot of people identify substance use problems. You just look like a guy that'd have one. So I'm going to ask you about it. That is not a great approach, in my opinion. Okay? That is not a great approach. So we want to learn from public health because public health routinely screens not for real things but for potential things and can identify them early. So let's look at how our treatment system actually kind of looks right now. And remember, I'm talking about myself. I've been in the substance use field for nearly 30 years. So I don't want anybody to feel offended when I talk about our system because I'm talking about my system. Okay? I'm telling stories about my family. Okay? I'm talking about my crazy aunt in the basement. Okay? So, basically, our system looks like this. Just a minute. Okay, just a minute. Let me start somewhere else before this slide. So that can stay up. Our system, by and large, is bifurcated. It's divided into two parts: prevention and what? And treatment. So prevention, we focus on adolescents. We spend a lot of time, money, and energy talking to them about not starting. So we're trying to preclude or delay onset, right? But if you work in our field and you do biopsychosocial assessments and you ask the magic question, how old were you when you started drinking? What do you hear? 14, 15, 12, 11, 9, whatever, right? Clearly primary prevention didn't work for those kids. Okay, just saying. So we try to stop it before it starts. But when that doesn't work, you know what we do? We just kind of forget about people until they get chronically or acutely ill with a substance use disorder. Their lives start to fall apart. They go see the judge, and the judge sends them to us. That's kind of our model. We try to stop it before it starts. When that doesn't work, we just wait until you get sick. Okay? I'm not sure that that's the right model. That's the model we've used, and that's kind of the model we have. Remember, SBIRT is a systems change initiative. And I'm convinced now, after 10 years of doing this work, that that model needs to change. So attendant with that model, besides being bifurcated between dependence or between treatment and prevention, we're sort of also bifurcated about how we think about the problem. What we have is, what does green mean in our country? Green mean go. We've got our green light people here. These are the no problem people. These are the people who drink responsibly. So what that means for most of these people is, Steve, I don't drink and drive. Therefore, I drink responsibly. I am a responsible drinker. Therefore, I don't have a problem. Okay? For these people, we give them primary prevention when they're kids, and then we just stop. And we don't have an intervention for them. Why would we? They're not sick. They have no problem. They drink responsibly. Why would you intervene on someone who doesn't have a problem? It doesn't make sense. Okay? So those are our green light folks. The thing about primary prevention, if the public health model had taken the substance use field model for prevention, here's what we'd do. We'd talk to kids about good heart health. Low salt diets, not too much fat, cut back on the bacon. I'm never cutting back on the bacon. Cut back on the bacon, don't smoke, do exercise, all that stuff. Then we'd just wait until they had heart attacks. Then we'd fix them. We certainly wouldn't give them a blood pressure every time they walked into our clinic. Why would we? We tried to stop it before it started. If that doesn't work, we'll just wait for you to get sick. Okay? That's kind of the model we got. So we've got the no problem people, and then what we have is, what does red mean in our country? Stop. We've got the red light people. For them, our goal for them, because our goal for these folks is to drink responsibly. Our goal for those folks is abstinence, right? And for them, for our green light folks, we don't have an intervention. They don't have a problem. Why would we? For our substance dependent folks, for our red light folks, abstinence is the goal and treatment is what they get, right? We have an intervention for them. So we've got people with no problem and people who are sick. That's really how it looks. Okay? Now, we can have the discussion about, oh, we've got an abuse diagnosis, which we don't anymore. Now we have mild, moderate, severe, and things like that. But frankly, that's pretty much how it works. And I would submit that most of the people who are in the red light, I was going to say the red light area, it sounds terrible. Most of the red light people, most of these red light people, how are they identified? We've already talked about it. They're identified through the courts. In fact, I would submit that they are pre-identified. I would even submit that they are self-identified. I would submit that my dog could identify them. That most of the patients, by the time they get to us, everybody knows they have a problem. Okay? Everybody knows. It's obvious. Not always, but most of the time. They've sort of self-identified. Okay? So they somehow went from being no problem people, green light people, to being red light people. And that can't just happen overnight. They didn't get up at age 12 and smoke a little reefer and then at 16 have a beer and at 25 have a couple of shots and then 3 glasses of wine and the next thing you know they're 40 and dependent. That's not how it happens. Something had to happen. They had to go from green to red somehow. Okay? And that's what we're going to talk about after the break. Come on in. We'll go ahead and get started again, everybody. Where we left off is we've got the no problem people, we've got the substance dependent folks. The no problem people, we just tell them to drink responsibly. We don't have interventions for them, why would we? And then we've got our red light folks, and these folks are already sick, and we want them to be abstinent. We have treatment for them. So if we looked at this as sort of on a continuum, it'd kind of look like this. Sort of look like this. Here we have people that are abstinent, okay? And they're abstinent for whatever reason they're abstinent. They're in recovery. They've got moral prohibition against drinking, or religious prohibition. They don't like the taste. Yeah, sure. They don't like the taste. Whatever it is, they're pregnant, whatever it is, okay? And then we have our responsible use people. And in our culture, based on the public service messaging from Anheuser-Busch, responsible use people do what? Or don't do what? They don't drink and drive, right. So then we've got all those people, those good people that drink as much as they want. They just don't drink and drive. And then, of course, up at the other end, we have the folks that are already chronically or acutely ill with a diagnosable substance use disorder, who are biophysically compromised, who are neurobiologically compromised, and who have a legitimate biomedical illness, okay? And remember, if we go back to just the red light, green lights, those people started as green lighters. Now, we could certainly have the discussion that some people are born addicted, or we have addictive personalities, or you just add alcohol and there's an instant alcoholic. We can certainly have that discussion, but by and large, nobody is a green light person one day and a red light person the next day. Something has to happen in between, okay? So, but that's kind of how the model looks. I think this model that we've been talking about is outdated. Just like 200 years ago, or 1935, Bill Wilson and Bob Smith, at some point somebody said, you know, I don't think it's a moral problem. They said, I think it's an individual problem. Well, maybe it's a family problem. It's a social problem. How we thought about the problem kept changing. It's continuing to change. So what I'm saying is we have an old model, and the model is not sufficient for what we know now. Could you imagine using a cell phone, even made 5 years ago? You would go, what are you talking about? What are they, this big, right? It's like carrying around a baby, okay? But a lot of our technology in our field is 100 years old, you know, or 80 years old, or 50 years old. Okay? We would never think of using that kind of technology. If you were still getting technology, 1950s medical technology, you would not like it. I've had some of that. It's not that fun, especially dental work in the 90s. Oh, it was terrible. I mean, you know, they were still dripping like, you know, ether. It was terrible. It wasn't that bad. But the fact is that as we learn, as we evolve, things change, and certainly how we think about things change. So the outdated model, by and large, describes the problem as sickness, illness, dependence. Remember, we try to stop it before it starts, but when that doesn't work, we pretty much don't do anything for you except maybe alcohol information school if you get a DUI. We wait until you get sick. Then you sort of self-identify, get in trouble, the judge sends you to us. That's kind of how it happens. Okay? So we have really focused on people who are dependent. Okay? It's terrible. I have worked for years with people who have substance use disorders. Nobody would wish that on their worst enemy. It's a terrible biopsychosocial illness. Nobody wants it. Nobody gets up one day and, at 8th grade career day and goes, alcoholic, that's kind of what I'm shooting for. Maybe a little heroin in there, because, you know, by the time I'm 30, I'm thinking I could really claw my way up there. Okay? Nobody does that. Everybody starts as a green light. And some people end up being red light people. But something has to happen in between. Okay? And so, but we have focused here. And that's fine for what it is. But it's not the right focus. We know more now. This is not the right focus. It's not a bad focus. It's just not the best focus. Okay? And I absolutely 100%, I think this is a wonderful campus. I think the work here that's going on here is fantastic. I think it's always going to be necessary. There's always going to be red light people. We're never going to stop it. So don't hear me saying that. I absolutely believe in abstinence. I believe the 12-step programs are fantastic community support systems, all those things. Don't hear me saying that. I'm just saying that we can all change the model because we understand things differently, and we can still have those things when we need them. But we need some other things as well. It's an outdated model. Because it doesn't recognize a full continuum of substance use behavior, a full continuum of problems, and then certainly doesn't provide a full continuum of interventions. And I'll talk more about that. So the SBIRT model, the old model, the traditional model, the model we have now really says, you know, the problem is dependence. People get sick, then they need help. Our model says that a substance use problem is actually excessive use. Remember, they start as green light and they end up as red light. That doesn't happen overnight. Something has to happen in the middle. And you know what happens in the middle? Excessive use. That's what happens. You cannot become biophysically addicted to a substance and go through all those biophysical changes, neurobiological changes, unless you experience high frequency, high dose exposure to that substance. You have to. Now, we can have the discussion that some drugs are more addictive than others, and they certainly are. Okay? We can have that discussion. But the fact is, you have to use the drug repeatedly, and you usually start to use it more often, and you use it in higher doses. So you have to have some high frequency, high dose exposure for the body to change enough to have a biophysical, neurobiological illness that we call a substance use disorder. You can't just get up one day and have it. You work your way into it by doing this, by using excessively. Here's some things excessive use results in. Trauma and trauma recidivism. If you talk to emergency room docs, which I do, they will tell you that somewhere between 75 and 90% of everyone who rolls through their door in a gurney has something on board. That they were loaded somehow, some way, when they got hurt. Hugely involved in trauma. Cause or exacerbation of health conditions. There are somewhere around 75 to 78 health conditions that can be caused or exacerbated, particularly by alcohol. Clearly, we know diabetes, hypertension, things like asthma, believe it or not, can be complicated. Okay, it goes on and on and on. Certainly all sorts of gastrointestinal problems, liver disease, et cetera, et cetera, et cetera. But there's somewhere around 70, 75, 80 problems, 80 health problems directly related to alcohol use. Exacerbation of mental health conditions. If you're depressed and you drink, you'll be more depressed. Okay? If you're anxious and take cocaine, you'll be more anxious, right? Just how it is. And we know that people will self-medicate. We understand that. Okay? But the fact is that if you're depressed and you drink because you're depressed, you're just going to be more depressed. That's the way it works. Okay? So it's going to exacerbate those conditions. And God knows we see people who come into our clinics, at least I know I have, and I'm sure you do, who have a right to be depressed. You know, they may be, you know, I used to see patients, they go, I'm feeling really depressed. And I'll say, well, tell me about your life. And they go, well, my wife left me and my dog ran off. My house burned down. I lost my car. My boss hates me. In fact, he's going to fire me tomorrow. And I'm living on the street. I'll go, and you're depressed? Why? Okay? That seems like a fairly normal response to me to a life like that. Okay? So sometimes we know people drink because they're depressed. Sometimes they're depressed because they drink. But a lot of times we see our clients that it's all wrapped up together, and maybe they should be depressed. But the fact is that drugs, alcohol can exacerbate that. Alcohol poisoning. I live now in Columbus, Ohio, home of the Ohio State University. Don't you guys just hate that? The Ohio State University. Here, I'll do a quick test. OH. Nobody in here. IO, good for you. See, that's the big call in Ohio. OH, IO. You yell that anywhere in Ohio and somebody will say IO. Ohio State, the Ohio State University. I know for a fact, and I've only lived in Columbus for 2 months, I know for a fact that at least one kid every year who comes to college at 18 goes to a big beer bong party, and what happens? He dies. Doesn't die because he's got a substance use disorder. Dies because he drinks excessively one time and gets alcohol poisoning. Happens all over the country. We hear it every year. I'm guessing it never happens at William and Mary. A little too buttoned down, I'm thinking. Okay. DUI. Here's an interesting statistic. Where I'm from in Washington State, we've been keeping records on DUI since about 1970. If you get a DUI in Washington State for the last about 40 years, you have to have a full biopsychosocial assessment to determine if you have a substance use disorder. Year in and year out, 75% of the people in Washington State who get a DUI do not have a substance use disorder. 75%. Date rape. Now, I'm not saying that alcohol or drug use causes date rape. What I'm saying is when people's inhibitions go down and their frontal lobes are impaired and they're not thinking right, that maybe no starts to sound more like yes, and maybe, you know, and all that stuff. We know this. Domestic violence, date rape, those kinds of things. Alcohol is almost always involved in those things. Almost always. Okay? That doesn't necessarily mean they're causative, that alcohol is causative. But alcohol certainly, should I say, lubricates the situation. Okay? You know, that makes it easier for it to happen. So domestic violence. Transmitters of STDs or STIs. I always wear a condom, except, you know, when I forget. That usually just happens when I'm, you know, on the ecstasy. Unintended pregnancies. And we are convinced. That's my wife. Yeah. By the way, if my wife calls, tell her I already left, okay? So that'll stop in a minute. I apologize for not turning that off. So excessive use results in all those things and substance dependence. In our model, substance dependence isn't the problem. It's a consequence of the problem. It's a result of the problem. It's a natural outcome of the problem. It is not the problem. The problem is excessive use because you have to drink excessively to get there. And all of these things may happen to people who have a substance use disorder, but I will guarantee you they happen to almost everyone who drinks excessively. At some point or another, they will experience something like this because that's what happens. You do not have to have a substance use disorder to experience all those other things. In fact, most people who experience those things do not have a substance use disorder. They use excessively. So we recognize that there's a full continuum of behavior, problems, and we're going to provide now a full continuum of interventions. Let me give you some definitions. We talked about this earlier. We're going to use the definitions from the National Institute of Alcohol Abuse and Alcoholism. And the reason we use these definitions is because these are the folks in our country, along with NIDA and some other groups, World Health Organization, who have been studying alcohol for years. They have studied it physiologically, socially. They understand, and we understand a lot about alcohol, how it functions, and this will speak some to your question. How alcohol functions in the human body, what it does to the body, what it doesn't do to the body, etc. So we're going to talk about healthy adults. Not talking about kids. We're not talking about my mother-in-law who's 94. Okay? Which I'll tell you a story about her in a minute. But so we're talking about your average healthy adult, like most of the people in this room. Okay? For men, less than 65, less than or equal to 4 drinks a day and less than or equal to 14 drinks in a week. The important piece here, part of what's important here, is that there's a daily limit and a weekly limit. The daily limit, we call that an acute measure. The assumption is that if I sit down and over the next couple of 3 hours I have 4 drinks, I will not get to 0.08. And if I don't get to 0.08, not only am I not legally intoxicated, in other words, I'm not going to get a DUI, I'm likely not going to be cognitively impaired enough to do things like get in a bar fight because I think you're ugly, okay? And I don't like your shoes, okay? But I do like your girlfriend, right? And the next thing you know, I'm in a bar fight, right? So that's likely not going to happen to me. I'm likely not going to fall down. I'm likely not going to forget to wear my condom. Okay? I'm likely not going to go home and get in a fight with my wife that ends up in violence because I'm intoxicated. The assumption here is, from an acute perspective, if I stay under that limit as a healthy man under 65, that my likelihood of harm, my likelihood of taking any risks or of having a negative outcome is minimal. My risk is low. The second measure, the weekly measure, is actually a chronic measure. And that measure says that if a healthy man under 65 over the course of a lifetime drinks less than 14 drinks or less in a week, and that averages out to 2 a day, which is something what you said, 2 a day, that their likelihood of having a chronic condition related to their alcohol use is minimal. They're not going to get a fatty liver. They're not going to get cirrhosis. They're not going to get esophageal varices. They're not going to have peripheral neuropathy. They're not going to have, any number of other things. Yes, ma'am? Well, we're going to talk about. Yes, women actually. One thing is alcohol is water soluble. I hate to tell you this. Women have more fat than men. You just do. And so we have more water than you. So we process better. And that's the basic gist. Generally, women are also smaller in stature. Not always, but generally. And so the limits are different for women. But again, what we have is an acute measure and a chronic measure. So for women, it's less than or equal to 3 drinks a day, less than or equal to 7 drinks in a week. And no, you can't save them up, clearly, because that would be over the limit, right? So you're all doing the math now. You're going, carry the 1. No, I'm good. So those are the definitions we use. Anyone who drinks at that level or below, we consider low risk. What they're at low risk for is that whole list of stuff I showed you that can result from excessive use. Now, let me tell you, I don't talk much about drugs for a number of reasons. First of all, SBIRT, while, for instance, people like the United States Services Preventative Task Force sees SBIRT believes that SBIRT is at least as valuable and as effective as flu shots and cholesterol screenings. That's how effective the people that talk to the Surgeon General and talk to the President believe SBIRT is. At least as good as flu shots and cholesterol screens, okay? It's a Class B recommendation. They recommend that this happen. But we don't talk for alcohol. The reason we don't talk about drugs much, there's a couple of reasons. One is they're incredibly difficult to study, street drugs, right? Because, what's your name?
Robin.
If I buy my meth today from Robin, okay, thank you, and I come over and again, Deborah, and I come over to Deborah tomorrow and buy my meth, am I buying the same thing? Likely not. It's like chocolate. Absolutely, thank you. Robin's the girl to know. Say if you need to connect here in the triplex. But the fact is that it's like oatmeal cookies and chocolate chip cookies. They both may be cookies, but there's nothing about the recipe that's the same, right? Okay, it's the same with marijuana. Yours is 25%. Yours is 40%, right? So who knows what my dose is? Right? So it's really, really hard to study the impact of street drugs because we don't really know what they are. And you can't just say, government, would you mind if I cook some meth and I'll tell you exactly what's in it, and then I'll start giving it to people and see what happens? Okay, that's not going to work. Okay, nobody's going to let you get away with that. So it's really hard to study drugs. The other thing is there's not enough evidence to support SBIRT for drug use specifically. We have anecdotal evidence from programs like mine that says people will reduce their substance use, marijuana particularly. Okay, but there's not a preponderance of evidence yet where people are buying into that. But for alcohol, so that's part of why we talk about alcohol so much. So we say anybody is low risk who's at that limit or under. People who are hazardous, we call them hazardous users or hazardous drug. Oh, let me finish that thought about drugs. We believe that any illicit drug use is risky. Okay? For any number of reasons. It's psychosocially risky because it's illegal, right? Okay? Plus, it's risky because I don't know what's in it. Even though I trust Robin to the core, she would never slip me any bad meth. I know she wouldn't. She's just too nice of a dealer to do that, a drug dealer. She's too nice. But the fact is that we believe that any illegal substance use is risky, which means we intervene. Okay? If you say, yes, I use illegal substances or recreational drugs, we would want to talk to you about your risk. Okay? So I just want to make that clear. But we call hazardous use, particularly for alcohol, a pattern that increases risk for adverse consequences. And that would mean anything over those limits. That increases your risk for bad things happening, falling down, forgetting your condom, getting pregnant, getting an STI, getting in a bar fight, whatever it is, getting a DUI. All your risk goes up. So we call that hazardous. Harmful is when negative consequences have already occurred. You've gotten a DUI. You've gotten in a bar fight. You've fallen down and bumped your head, etc. So that's how we describe it. And then, of course, we still have folks that are red light folks and dependent. So the old model, again, right, looks like this, except we've changed some stuff. First of all, we've defined what drink responsibly means. Drink responsibly means at or below those NIAAA limits. Now we've defined it objectively. We know what responsible drinking is, and it doesn't mean don't drink and drive. Yes, ma'am.
It may be early to jump in with this, but the vast majority of patients I work with have co-occurring psychiatric disorders, and I'm not talking only about anxiety and depression, but schizophrenia,
Sure.
some severe persistent now. So I'm thinking as you talk that the hazardous use pattern for them is not as easily defined.
The only low-risk choice for that population is abstinence.
Only low-risk.
That's what I would say.
Well, and then interestingly though, I don't think they would say that.
Well, I'm sure they would.
But I'm trying to, at least these days, give them, their history of trauma, their history of self-medication, those kinds of things. And they don't want to talk about it if all we can talk about is abstinence.
Yeah, absolutely.
A lot of the time.
I'm gonna talk to you about a way to talk to your patient about this.
I appreciate it.
Okay, that's one of them. She's absolutely right. And I'm going to come right back to that. Okay, so but give me a minute. Basically, let me be really clear. This model supports abstinence. You want to stop drinking? We're good with that. Anytime. That's the only no risk. Notice I didn't say if you're under those limits. I didn't say it's no risk. It's low risk. See? So it's sort of like how many people wear their seatbelt? If you want no risk, stop driving. Right? If you want to lower your risk of what? Injury, wear your seatbelt. Okay? The only no risk is not to drive. Probably not to walk either, because I think it's dangerous being a pedestrian too. But you know what I mean. What we do is we mitigate some of the risk. One of the ways we mitigate risk with alcohol is recognizing that there are objective limits that say if I stay below these limits, I should be fine. My risk is low. Okay? There are people, and this is an individual. Remember I said normal, sort of healthy adults. Back to my mother-in-law, who is 94, who lives by herself in a 3-bedroom rambler, which she has just remodeled. She took her car, I swear to God this is true, she took her car to the mechanic just a couple of months ago. She's 94. And he said, what do you want me to do to the car, Dorothy? He says, just fix anything that could break in the next 6 years. She's 94, okay? That's pretty spry. She doesn't take any medications at all. Now, occasionally after she shoots a round of golf, okay, I swear to God, she will have a beer. I'm okay with that. Once in a while, she'll have a glass of wine. I'm okay with that. She has 2. I'm not okay with that. The woman's 94. She's this tall. She shouldn't have 2 drinks. 1 drink is fine. If she was on a handful of medication, I wouldn't want her to have 1 drink. Right? Okay? Because I know that at her age, her risk of falling when she's sober is pretty good. Let alone if she had 2 drinks in her. And then if she was on medication, right? And you see where I'm going. So part of this, we have to think about the individual that we're dealing with. That's an important caveat. Okay? We have to think about this individually. We support the SBIRT model, and so I say we, support abstinence for people who have chronic mental illness. We would support abstinence for adolescents, pregnant and parenting women, pregnant women particularly, people with immune deficiencies or other chronic conditions like diabetes, and also people who have a substance use disorder. The only low-risk choice for these folks is no risk, right? Is to not use. How I would talk to and young lady, what's your name? Laura? That's all right. Laura, I'm used to women ignoring me. It's okay. Laura? Is it Laura? How we talk to our patients is we don't, let me ask you this. Here's a way to frame this. Who's got the best idea in the room? That's right, I do. I have the best idea in the room. That's just the way we are as human beings. Which means your patient has the best idea in the room. Which means if you can get your patient to say it, it's going to be the best idea in the room. So we take an approach that says, we say things like, so we've talked about how alcohol might negatively interact with your medications. What do you think you might want to do about that, Laura? Great! That's fantastic. Okay? Now I would want to get that really clarified. What does that mean? Right? And get some real numbers. But I'm telling you why I'm going to say that's great and why I'm going to go with that. Because I believe in high school physics, we learned a little lesson, and it said an object in motion tends to stay in motion. If I can get someone to agree to a change, and they follow through and maintain that change, they're much more likely to make another change in the same direction. So rather than starting with abstinence, we frequently say, what would you like to do? Well, I'll cut from 10 beers a day to 8. Fantastic. That's 10%. I'm okay with that. Is it perfect? No. Is it low risk? No. You know, in my wonderful little idealistic head, is that what I'm hoping for? Absolutely not. But it's going in the right direction. And I will guarantee you, if I chase my patient, and this is part of your concern, if I chase my patient out of the room, I cannot treat an empty chair. I am convinced about that because I have tried. Okay? And the chair just will not respond. Come on. So in our model, we use motivational interviewing as our clinical model, our evidence-based clinical model. And this is our approach. Our approach is, what do you think you want to do? And then we support that as long as it's going. If they say, I'm going to drink more, we go, okay. But generally, if they say, well, I'll cut back. How much will you cut back? When will you cut back? Are you talking about today? Let's make an agreement. Okay, we get that real concrete because we want them to go in that direction, but we also want them to come back, right? And so the worst thing we can do a lot of times is say, you got to stop. Because if they say, I think I'll stop, it's the best idea in the room. If I say it, what happens? Oh, Steve, I don't know. Dude, slow yourself down.
I have a question. It's not exactly related to this, but what I'm hearing you say is a little more like damage control than they're going in the right direction. What I am confuses me now because I'm older, and I actually did my internship in one of those old mental hospitals. And the people there were schizophrenic, they were on Thorazine, and they smoked cigarettes all the time. And I was just walking around this Eastern State thing, and we are a smoke-free environment. And I always believed, with my education, that the cigarettes actually did calm them down. It was a type of medication, like a damage control. So I don't understand this whole new concept of no cigarettes when these people are suffering with schizophrenia, and it might have given them relief.
Well, you know, I think I can't really comment to that. What I would say, just if I think sort of globally about an issue like that, says is calming someone down worth them becoming a patient with emphysema and schizophrenia?
I don't know. I mean, they're heavy-duty drugs. Their quality of life was pretty bad, and they, state mental hospital.
Yeah, see, and I think those are policy and philosophical questions, and I think those are worthwhile questions to
I would like
ask.
to say that right now, at Easter State Hospital, the quality of life is really good.
Okay.
No, they
No,
cannot.
I don't know. I mean, I just remember
They can smoke on ground. They cannot smoke on ground. So I
They
just
used to
wanted
get
to
such
say that. It's not like it was before.
I want you two to talk after and resolve this physiological debate. So, here we go. Remember our green light people and our red light people? Now we've defined what this means. Drink responsibly means at or below the low risk limits, right? We're going to still do primary prevention for these people, but you know what we're going to do now? We're going to do primary prevention across a lifetime, just like the medical facilities do. They don't stop talking about your heart. How old are you, honey?
26.
26, I would have guessed way younger. Good for you. But if again, we're not going to just stop talking to you about prevention, good heart health when you're 12. We're going to keep talking to you your whole life. Does that not make sense? Of course, it's lifelong prevention. Thank you for letting me pick on you. I would have thought 17. Okay. Good God, I have a daughter your age. I have shoes your age. I'm just saying. So the whole idea here is, why would we just talk to you when you're a kid and then stop talking to you about prevention? Doesn't make any sense. So we're going to talk to people for their whole life. We're going to do lifelong prevention. And lastly, we are going to actually identify these people, because we're going to give them a screen. I can identify those people in less than 30 seconds. Okay? And we're going to validate the fact that they're doing well. Right? We're going to say, good for you. Because while most people know H1N1, cough in your arm and wash your hands, what do they think responsible drinking is? Don't drink and drive. We want to educate them so that they know there's actually a quantitative measure that you can use as a standard, because most people don't know it exists. Okay? So we're going to do prevention with those folks. These folks up here, the substance-dependent red light folks, we still want them to be abstinent. We're still going to send them to treatment, but we're also going to screen them, identify them, and refer them with any luck before the judge sends them to you. My hope, my big idealistic hope, is that one day in our field, in the substance use field, most of our referrals will come from doctors, not from judges.
Don't you, though, rely heavily upon self-disclosure? And it's been my experience, as limited as it is in this field, that people will lie to you about what they've done and what they're doing.
Absolutely true. Let me address that. You're working from a narrow population base that you've generalized to a broader population, and it's a myth. And here's why. And it's a myth that most people hold. Okay? People will not be honest about their substance use. That's the myth. Now, that myth may not be completely wrong when we talk about patients who have been referred by who? The courts, who may have a vested interest in being less than honest. Yeah? Would you agree with that? You ever write this in the chart? You'll love this. You ever write this? This is how you know I used to be a clinician. I mean, I actually used to go like this. Okay, pick up the chart. That's kind of funny. And I would write, the veracity of the patient's self-report is in doubt. Yeah, because I couldn't write liar, liar, pants on fire in the chart. It just wouldn't look good, right? Okay, you just can't look, you just don't look professional when you do that. So you write the veracity of the patient's self-report is in doubt. So you're absolutely right. with a narrow slice of the population, they will have a vested interest in not being candid with you for any number of reasons. Sometimes the reason is because I know you'll tell me to quit, right? You're not going to tell me to cut back. You're not going to tell me it's okay. You're going to tell me to quit, and I don't want to hear that, and so I'm not going to be honest. Most people, particularly in medical environments, will be candid about their substance use, and the reason is because here's my question. If you walk in, what's your name? Jennifer. In the last 12 months, have you at any one time had 4 or more drinks on one occasion? She just ruled out, and I'll bet that was an honest answer, wasn't it? Yeah, absolutely. You know why she will answer that honestly? Why? Because 4 doesn't seem like that much. Sure, I went to a wedding. I had 6 glasses of champagne, so what, right? Doesn't seem that much. For men, we say in the last 12 months, have you had 5 or more drinks on one occasion? You know how many men drink a 6-pack when they watch the game? It doesn't seem like much. They're not invested in lying about it because why would I lie about something that's not problematic for me? Well, I wouldn't. Okay? People, particularly in medical environments, are remarkably candid. Here's one of the ways I know. Well, let me finish this and I'll come back to that. So that's the old model, except we've added some things, and we've added this. Now this starts to look more familiar, doesn't it? This starts to look, what does yellow in our culture mean? Caution. Whoa, these are the excessive use people. Okay? So now we have the green light people, the red light people, and the yellow light people. For them, what we want them, what our goal for them is low risk use. Down here, it's we want them to stay doing what they're doing. These people, we want them to change what they're doing, and those people, we want to be abstinent. But we're not talking about these people necessarily being abstinent. They're not sick. They're healthy adults. If they drink 3 or less for a woman or 4 or less from a man and 7 or 14 in a week, their risk of harm is very low. Okay? So we're going to provide them with a screen. We're going to identify them. We're going to give them a brief intervention. We're going to talk to them for 5 or 10 minutes to assist them in making a behavioral change related to their substance use, okay, to move from risk to low risk. I'm going to talk a little bit more about that. We can also give them something a little more intense that's way less intense than traditional treatment. But that's kind of our model. So what we say is we recognize there are actual responsible drinkers, great for them. We recognize there are people who are already chronically acutely ill and we want them to access the care that they need. But we also recognize that nobody goes from green light to red light overnight, that they pass through this excessive use, this yellow light place, and that's where we can intervene most effectively. Here's what we know. If you look at the data for years on the substance use side of the house, our success rate, 35, 40, 43, 38% every year in and year out. And people look at our field and they go, what in the hell is wrong with you people? Okay? Why can't you do a better job? Well, I'll tell you why we can't do a better job. It's because our people are so chronically ill by the time we see them that their chance of recovery is minimal. That is why we do an outstanding job to get 40%. Are you kidding me? Okay? If all cancer doctors, if all oncologists waited till every one of their patients needed a radical mastectomy before they started treating them, their success rate wouldn't be 40%. They'd win the Nobel Prize in medicine if they could get 40% from that population. You understand what I'm saying? We wait for our patients to be so ill that their chance of getting well is small. And I think that's, I don't like that anymore, and that's what I used to do. And I'm not saying those folks are a dependent population don't need us, because they do. I've worked with that population for years. All I'm saying is I think we can do a better job helping people not get sick. That's what I'm saying. So now we kind of look like that. Let me show you this graph. This is there are 100 dots on the board for all you OCD people who are now counting. Just stop it. Okay, there's 100 dots there, and you notice we're going to assume that everybody's a green lighter. Well, if we actually look at the non-institutionalized adult population in the country, what we find out is only about 4% at any one time is dependent. Now, that may come as a shock to you because you work in our field and that's who you see, and you're thinking, oh my God, the whole world's dependent. Well, it's really not that much of the population. At any one time, when the CDC, and we've done these epidemiological studies all over the country for years and years, at any one time, about 4% of the population is actually dependent. Okay? However, about 25% of the population is using excessively, which means they're at risk for all those psychosocial and healthcare problems we talked about and dependence, right? Okay? They just haven't moved from green to red yet, but they're in the yellow range. They're caution folks. They're yellow lighters. They're using excessively. And here's how this sort of looks at a pyramid. So at the very top, dependent, 25% in the middle, 71 at the bottom. So when I ask that single question screen, I anticipate that somewhere between 25 and 29% will answer honestly, or will answer positively, right? Because that's where the number should be. I have asked that question to somewhere near, and I mentioned this before, about 500,000 people. You know how many are positive? 25%. Sometimes it's 23, sometimes it's 28, but it's always right around 25, which tells me two things. First of all, people are answering honestly. And second of all, this is what the data says we should find. The data says about 25% should be positive. When I ask 500,000 people, I find about 25% are positive. Okay? So I know I'm asking the right question. The questions that I ask, like that NIAAA single question, in the past 12-month question, we also asked that about illicit drugs and prescription drug use. But that question captures between like 75 and 90% of everybody you want it to. And the idea here is, remember I said we would identify it differently? Again, I identify in about 30 seconds because what I'm looking for is not dependence. I'm looking for risk. It's a different thing to identify. I don't diagnose anybody. What I do is identify their risk. And I can do that in about 30 seconds. So that's kind of how people break out. And they break out that way in big populations as well. So our model looks a little more like this. We've still got the green light people. Okay, except now we call them low-risk users rather than responsible users. And we also have added experimental use. I will guarantee you experimental use is going on in 2 states right now. You want to name the states? Washington and Colorado. There's a lot of experimental marijuana use going on right now because people will give it a try who would never try it if it was illegal, right? They wouldn't step outside that social boundary. But now that they're not stepping outside of a social, sure, I'll give it a try, what the hell? Okay? So there's going to be lots of experimental use going on. And then you've got low-risk use. We've still got our dependent folks, okay? But now we've added these folks, okay? We've got the hazardous use folks, which means they're over the low-risk limit. We've got the harmful use folks, which means they're already experiencing problems. And the symptomatic use folks, which means they've got a symptom or two, but just not enough to be diagnosable, but they're well on their way to joining the red lighters, okay? So our goal, that's a 6-to-1 split. For every one patient who has a substance use disorder, we have 6 who are at risk for a substance use disorder and all that other stuff. They just haven't got it yet. So the bulk of the societal, personal, and healthcare related costs are not the result of people who have a substance use disorder. Results of most of it is because of excessive use. And we need to acknowledge that excessive use is the problem, address it appropriately. Unless we do that, we're unlikely to find a solution. Consider this. I'll let you just read that. If I could cure every single substance use disordered patient in our country right now, today, with the magic bullet, which I would do in a minute if I could, I'm still not going to come close to solving the problem. In Washington State, I'd only cut into DUI by 25%. Now, that's great, but it's not enough, right? Most of the cost in our country is because of excessive use. When we talk about alcohol being the third leading cause of preventable death, not because people with substance use disorders are dying. People who drink excessively are dying for any number of reasons, right? That's where the cost is. Not only that, when you think about healthcare in the United States, the biggest cost drivers in our system are behavioral. I talk to docs. I spent the day talking to docs yesterday. I talk to docs all the time. You say, when people walk in your door, what are the two things you see most often? It doesn't matter where I'm at. I asked this question in Virginia this week. I asked it in Ohio last week. And the week before that, I was somewhere else and asked it. Where the hell was I? It doesn't matter. Yeah, so much for smoking those reefers the size of a corn cob, huh? But what the hell question was I asking? Absolutely forgot where I was. Oh, yeah. I asked them, what are the primary presenting problems that you see? Thank you. That will walk in the door, and they always say hypertension and diabetes. I'll say, well, that's interesting. So when you talk to your patient, let's say your diabetic patient, what's something you might say to them? Tell me about your diet. This sounds like behavioral stuff to me, right? Same with the hypertensive patient. Bob, you still smoking? How much stress are you under? It's behavioral, right? Substance use is a lifestyle-related choice. It is behavioral. When we talk about substance use and doing things like a brief intervention, 5 or 10 or 15 minutes talking to a patient about their risky substance use, we're talking about assisting them in making a health behavior change. Because we frame this as healthcare, which is another reason why people are more honest with us, because we frame it as a healthcare issue. And frankly, most people don't want to take risks with their health. Most people. I'm not talking about the folks that are already substance use disordered. They're already really chronically ill, okay? They have a biophysical and neurobiological illness, right? When we're talking the yellow light people, we're not talking about people that have a disease. We're talking about people that are making a choice to drink like they drink, and they can make another choice. Sometimes just having new information will drive them towards a better choice. Just the information, because they've got the same information we do, which is drink responsibly. That's what they think they are doing, because that's the information they've been given. They don't know there are objective measures. They know H1N1, okay? They know this, but they don't know that over 4 for a man is too many. They don't know that. So part of what we do is educate. But if I could fix everybody, I still would have a huge problem. So our goal is not to identify those who are dependent. Our goal is to identify those who are at moderate or high risk and assist them in making changes to reduce their risk. That's what we want to do, because that's where we think we're going to make the most impact. Okay? If excessive use is the problem in our model, then that's what we have to address, excessive use. And nobody goes green light, red light overnights. They all pass through the yellow light phase. That's where we want to identify them. Okay? So we use a public health approach. We can immediately rule out the non-problem users using that single question. Then I can ask a few more questions, identify levels of risk. I'll identify patients who I can talk to for a few minutes, and they are likely. The evidence shows, by the way, SBIRT is entirely evidence-based, or people like the AMA wouldn't support it. And the data suggests that people will change their behavior, which again is a myth. One of the myths we have working with the narrow substance-dependent population is people will never self-select into behavior change. They have to be forced into behavior change. Now, that's the old model, and that model specifically comes from Alcoholics Anonymous. Because what do you have to do before you'll change? Hit bottom. Driven under the lash of alcoholism. Right? So that's an old model. The old model says you have to hit bottom before you'll change, and we've taken that for this very narrow group of substance-dependent folks, and we've generalized it to everybody. Frankly, that's not true for most people. Most people are willing to change when they find out they're taking risks. Okay? Not everybody, but most. So we have wonderful data from controlled studies that says people will change if I can talk to them for 5 or 10 minutes. So we can also identify those patients who would benefit from higher levels of care. The good thing about SBIRT is when I identify those patients, they're 2 to 3 times more likely to go to treatment if they need it, if they talk to me first. Okay? So that's a good thing. And lastly, we can do progressive levels of intervention based on need and motivation for change. So clearly, we're not necessarily abstinence-based. We're not going in and saying you have to stop drinking to people. We say stuff like, as we talked in the back, so now that you have this new information, what do you think you might do? Okay? So here's the moving parts. Pretty simple. We screen everybody, just like you get a blood pressure. It's a universal screen. If that's positive, if it's yes to those couple of questions, or that single question, then we give you a fuller screen. We recommend the Alcohol Use Disorders Identification Test, which was developed by the World Health Organization. We can do a brief intervention then for those. We can do extended brief interventions, more than one if necessary, and we can refer then to traditional treatment. So it's pretty straightforward. I was going to mention something back here. Where was it? I don't remember. So before I go about that, we're almost ready to stop, and I'm right on time, amazingly enough. Let me tell you about my friend Bob. Bob is a barbecuer. What's the favorite football team around here? The William and Mary, I'm sorry? The Tribe, okay. So my friend Bob is a rabid, is a rabid Tribes fan. And so he watches the game every Saturday. And during the game, Bob drinks 2 beers a quarter. Okay? So what do we know about Bob's drinking right now? He's at risk. In fact, he's twice over what we would consider the basic cutoff for a man on a single day, right? He's drinking 8 instead of 4. Okay? 2 beers a quarter. Does this seem excessive to Bob? No, he's drinking 2 beers a quarter for, and a game can go on for, 3 hours, right? 2 beers a quarter ends up being a half an hour, 45 minutes, that kind of stuff. So you drink a couple of beers, not a big deal. So after every game, Bob barbecues. And Bob's a real barbecuer, not one of these propane barbecuers. Okay. So he goes out, opens the lid of the barbecue, he pours in the Kingford, because it's always Kingford, right? Okay. And then what does he have to do? Got to have lighter fluid, right? And, those lighter fluids got that little stem on it. Oh, no, that's not going to work. Okay, Bob has to take the top right off because, you just need more lighter fluid. Yeah, you all know where this story's going. And so, yeah, that Bob drills it on there really good. And then Bob lights that little thing, this little thing. Remember we used to have a match, but now we got this little thing. And he goes, whoa. Okay. So Bob, like all good American males, go, I'll just walk it off. Okay? And so he cooks his steak, he eats his dinner, he goes in, he goes to bed, he gets up in the morning, he goes into the bathroom, he looks in the mirror and he goes, oh my God. And his eyebrows are gone and he's got red patches and a blister. And so he says, this is terrible, but I'm going to have to go to the emergency room. I mean, I'm going to have to go get this looked at. I really wished I didn't. And so Bob puts on his suit because, well, he's a congressman. And so Bob puts on his suit, and then he goes to the emergency room, and he walks in, and the nurse says, Bob, what in the hell happened? And what does Bob say? What does Bob say? Bob says, I was lighting the barbecue, and it must have got away from me. They treat his burns, and they sent him home. At my hospital, at my medical clinic, at the medical clinic I hope you go to, when Bob walks in and they say, Bob, what the hell happened? he says, well, I burnt my face off barbecuing. And then they say, were you drinking? But that's not what they say. They say, Bob, at any one time in the last 12 months, if you had 4 or more drinks on one occasion, he says, well, hell yes, yesterday. What do you think happened here? Okay, right? Now, there's a whole different thing going to happen, isn't there? When Bob first walked in, he was burnt. Now Bob walked in, not only was he burnt, but he was burnt why? Because he was likely intoxicated. Okay? So I'm going to talk to Bob about, and I'm going to help him understand that maybe the burns are a result of the 8 beers. And I'm going to say, so Bob, now that you have this new information about safe drinking limits or low risk limits, what do you think you'll do? Bob says, well, Steve, I'll just drink 1 beer a quarter. Right? And now Bob, I have successfully helped Bob, literally in 5 or 10 minutes, reduce his drinking by 50%. Right? I've taken him from risk to low risk. Real easy. It happens all the time. We see it happen all the time. That sounds too good to be true, doesn't it? And it really does. Okay? Because we work with this narrow, terribly, chronically ill, impacted population all the time. We can't imagine that people would change that easy. But they really do. Sometimes they really do. And the data, if you wanted to go out today, you could Google data for SBIRT, and you'll find that patients reduce their use usually between 10 and 30%. Okay? Is that perfect? No, but for a lot of people, that's enough. Right? For Bob, going from 8 to 4 was great. If Bob would have went from 6 to 4, what's that? 30%? Okay? It's not a big change. Doesn't have to be to go from risk to low risk. But his chance of all those other things happening now gets really small. So that's what we're always trying to do. We're trying to find guys like Bob that we can assist in making little tiny changes that have a big result. And Bob's a classic example. We see people like that all the time. So just really quickly, ours is a system change initiative. We're going to think different about substance use problems. We're going to redefine how we identify them and redesign how we treat them, because I'm going to treat them in 5 or 10 minutes. I'm going to use a public health approach. I'm not going to think the problem is dependence anymore. I'm going to think it's excessive use. And I'm going to talk about a continuum of behaviors, problems, and interventions. Hey, and that's me.